The end of the endotracheal tube should lie in the mid-trachea 3 to 7 centimeters above the carina. A good rule of thumb is 22 centimeters at the teeth for the average size adult. Place the end-tidal CO2 detector onto the endotracheal tube and attach the ventilation bag, administering a few tidal volume breaths. Carbon dioxide will be reliably and consistently detected within the first 6 breaths of an endotracheal intubation, and with each exhalation thereafter, except in some cases of cardiac arrest when gas exchange may not occur. Assess secondarily for esophageal tube placement by auscultating over the stomach during positive pressure ventilation. Auscultate both lungs in the mid-axillary line to assess for equal bilateral air movement. If breath sounds are diminished on the left side after intubation, you may need to gradually withdraw the endotracheal tube until symmetrical breath sounds are auscultated. Chest radiography is used to assess the patient's pulmonary status after intubation and to ensure that the tip of the radio-opaque line embedded in the endotracheal tube is well positioned at the level of the mid-trachea and not in either mainstem bronchus. Note that radiography cannot be relied upon to detect esophageal intubation. Secure the endotracheal tube to the patient's head once proper position has been confirmed. If available, you should use an endotracheal tube holder to secure the tube, as these devices aid in the prevention of accidental displacement. If such a device is not available, tape may be used instead. First, attach the tape to the patient's cheek and then wrap it circumferentially around the tube. Next, affix the free end of the tape to the patient's other cheek. Pharmacologic sedation and hand restraints may be employed to prevent inadvertent extubation. The most serious complication of endotracheal intubation is unrecognized esophageal intubation, which may lead to hypoxemia, hypercapnia, and death. Laryngoscopy can provoke vomiting and aspiration of gastric contents, causing pneumonitis or pneumonia. Additional complications include bradycardia, laryngospasm, bronchospasm, and apnea due to pharyngeal stimulation. Trauma to teeth, lips, vocal cords, and exacerbation of cervical spine injuries can also occur.